Good afternoon. My name is Gerard Millen, and I'm a paediatric oncologist at Birmingham Children's Hospital and an honorary clinical trials fellow at the Cancer Research UK Clinical Trials Unit at the University of Birmingham. And I was one of the co-chairs of the Paediatric Coronavirus Cancer Monitoring Project. And I'd like to tell you a bit about that in the next 5 or 10 minutes. It's back in spring of last year, as the COVID pandemic was just beginning to accelerate and spread outside of China. We had very little information about the severity of COVID in children and young people with cancer. And there were some quite mixed messages coming out of China. It appeared that children overall were at lower risk of severe infection, but adults with cancer seemed to be at risk of more severe infection, and we weren't sure how those two things would interplay in children and young people with cancer. So in the UK and around the world, urgent measures were taken to protect children and young people with cancer by implementing shielding, by modifying the way we as doctors and nurses cared for patients, but also by making some changes to the treatments that we were giving to our patients. It was clear that we needed to collect data on the severity of COVID in children and young people with cancer so that we could accurately define those risks, but also share that information in real time and make informed decisions on the best way to continue to care for children and young people with cancer. For that reason, we set up the UK Paediatric Coronavirus Cancer Monitoring Project, which had a very similar model to the adult project, which was launched in the middle of March last year. So we invited members, academics, and clinicians from around the UK to join a steering committee, and crucially had the help of the Children's Cancer and Leukemia Group, without whom the project wouldn't have been possible. Via the CCLG, we approached each of the principal treatment centres in the UK. So these are the large hospitals that care for children and young people with cancer. And we also set up the ability for the shared care units that are affiliated with the principal treatment centres to share data also. Crucially, all of the data was anonymised at the local hospital and then was loaded by the local team into a secure browser, which was based at the University of Birmingham. And this was very important so that as a steering committee, we didn't have access to any patient identifiable information, so only the local teams knew who their patients were. We took the decision to exclude patients who had a stem cell transplant, as this data was already being collected by the European Bone Marrow Transplant Registry, and we didn't want to ask clinicians to duplicate this work unnecessarily. We developed a questionnaire which was browser-based, and after asking some very basic information, we then wanted to get down into the nitty-gritty. So what were the signs and symptoms of COVID that patients are presented with, and how severe was their infection? What type of cancer did they have? What treatment patients had, both to date, but also within the past month? And those things went together because we wanted to know whether any particular types of cancer or any specific treatments that seemed to put patients at increased risk of severe infections with COVID. And then finally, we wanted to know what were the outcomes that were related to the COVID infection. Did most patients have a mild self-limiting illness, or were there more severe infections that we were seeing with patients needing intensive care support? So we launched the project in April last year, and within just over 3 weeks, all of the principal treatment centres around the UK had signed up to contribute data. And again, that wasn't possible without the work of the CCLG. We were sharing the data on a real-time basis with the CCLG, particularly if we identified any severe or critical cases, so that if there was a clear signal that we were seeing severe infections, we could rapidly make decisions on that. After about 6 weeks, we developed the infographic, which hopefully many of you have seen. And we wanted to share the information that we had at that point with the wider community around the UK, including patients and families, so that you could start to make decisions as well based on the data that we were seeing. Over the course of the summer, we continued to share data with the CCLG, who were able to input into decisions on shielding. And so over the course of last year, the majority of children and young people with cancer were no longer required to shield and were taken out of the extremely vulnerable group. And then in December last year, we had our initial publication in the British Journal of Cancer, outlining in more detail the information that we had gathered up to that point. So where are we up to now? It was clear as we progress through this summer, that we as a country were thankfully moving into a different phase of the pandemic. And so we took the decision to stop collecting data, as the messages from the data have been very stable for some time. So by the time we closed the collection at the end of July, we had almost 150 patients registered overall. And as you can see from the table on the right, the overwhelming majority of children and young people with cancer who developed COVID had either a very mild infection or were completely asymptomatic and were picked up as part of routine screening. The very clear message is that we didn't see any increased risk of severe infection in children and young people with cancer. And thankfully, no patients in the UK died with COVID infections. The vast majority of the principal treatment centres were able to contribute patients to the database, and particularly during the first wave of the pandemic, we were very confident that we managed to get all of the positive cases that were identified around the UK. The most common symptoms that we saw in children and young people with cancer were fever and cough and cold symptoms, and that's not surprising given that they're both the most common signs and symptoms seen with COVID generally, but also fever is far and away the most common reason that children or young people with cancer need to come back to hospital after they've had chemotherapy. Over a third of patients were picked up just on incidental screening, either prior to an anaesthetic for a lumbar puncture or bone marrow, or before an admission to hospital for elective chemotherapy. Crucially, over the second half of the pandemic, as new variants have emerged, we haven't seen any change in the data to suggest that there's been an increased severity with new variants. There are a huge number of people I need to say thank you. So firstly to the steering committee and a wider team at the University of Birmingham who helped run the database and with the data analytics side of things. But finally, I'd like to say a huge thank you to the volunteers from the principal treatment centres around the UK. Without their hard work and without them taking the time to submit the information, we wouldn't have been able to collect this data to show that in the UK, the vast majority of children and young people are at no increased risk of severe forms of COVID if they have an underlying diagnosis of cancer. So thank you for your time.